morning. It's 8 o'clock, so I think we'll go ahead and get started. This is free paper session 18, Pancreas 5. My name's Attila Nakib. I'm from the United States, Indiana University. Professor Anderson's from Lund, Sweden, and so we're going to co-moderate. We'll ask all the discussants to actually go to one of the microphones because the session is going to be live streamed, so we can get that recorded and transcribed here. So we'll go ahead and get started. The first paper, Impact of Liver Disease and Parenchymal Changes on Patterns of Liver Recurrence in Patients with Resected PDAC, a new insight into biologic behavior of this lethal disease. And this is from the, we just call it the Johns Hopkins group, and Dr. Javid's going to present.
All right, thank you. I'd like to thank the IHPBA for giving us an opportunity to present our work here today. I have nothing to disclose. So pancreatic cancer remains one of the most lethal malignancies, and even a majority of patients undergoing curative resection will experience recurrence of disease. And the predominant pattern of recurrence is systemic, as can be seen here from this figure. Even amongst those patients that recur distantly, it has a propensity to go to the liver. So why is that the case? So recent literature or data suggests that the primary pancreatic cancer cells, they prime the liver through molecular signaling, usually exosomal and proteomic signaling, and the subsequent cytokine and chemokine release results in a lot of changes, which leads to what we call a pre-metastatic niche formation. And this provides the optimal microenvironment for the circulating tumor cells to seed the liver and lead to micro and then macro metastatic disease. The literature available on pre-metastatic niche was beautifully summarized in this paper out of Netherlands, where there are multiple different processes that are going on, and a lot of it is driven by molecules coming from the primary tumor. So firstly, TIMP1, which is released by pancreatic cancer cells, when it reaches the liver, it activates the quiescent hepatic stellate cells, and downstream results in neutrophil recruitment. Similarly, MIF, positive tumor-derived exosomes, act on the Kupffer cells and then release TGF-beta, which then activate these hepatic stellate cells, resulting in release of fibronectin. Similarly, tissue factor basically works with the platelets, changes the fluid dynamics in the liver, and helps with extravasation of circulating tumor cells. And then metastases-associated macrophages in the liver release granulin, which again activate the hepatic stellate cells, resulting in increased production of periostin collagen. Together, all these different processes result in the pre-metastatic niche formation, followed by extravasation of CDCs, which results in micrometastatic disease, followed by macrometastatic disease, which can be appreciated on imaging. So how can pre-existing liver disease impact the rate of liver recurrence? And in order to really understand that, we have to go back to the 80s. This is probably the most convincing data out there, where they did a bunch of autopsy studies, and they found out that patients who had cirrhosis, in fact, did have a lower rate of recurrence in the liver. And since then, not a lot of work has been done in pancreatic cancer, but work on CRLM has suggested low rates of liver metastases in patients who have background cirrhosis. So with that in mind, we wanted to assess the impact of liver disease and parenchymal changes on the rate and timing of liver recurrence in patients with resected pancreatic cancer. Around 1,200 patients who underwent surgical resection for pancreatic cancer between 2010 and 2017 were included. Those who had post-operative mortalities or presence of intraoperative occult metastases or any other concomitant malignancies were excluded. And to identify liver disease or parenchymal changes, the patient's radiological imaging, their past medical history, and in a few cases, histopathological analyses of liver biopsies were assessed. And then the type of liver diseases that were identified included fatty liver disease, perfusion changes, cirrhosis, fibrosis, granulomatous disease, and textural changes. So at baseline, there was not a lot of difference between the two groups, those who had and those who did not have liver disease. The ones with liver disease tended to be younger, and it was more frequent in the female population. And in terms of their histopathological features, there was no significant difference in terms of tumor size, grade of tumor differentiation, presence of nodal disease, and marker status. So what happens when you look at liver-specific recurrence-free survival? On univariate analysis, the same traditional factors, tumor size, nodal disease, grade of differentiation, they were all associated with liver-specific recurrence-free survival, but we also found out that presence of liver disease was strongly associated with liver-specific recurrence-free survival, and this remained true on the multivariable analysis as well. So when we looked at the impact of liver disease and parenchymal changes on recurrence-free survival, and this is all recurrence, we did see a significant difference, but we wanted to see whether it was specific to the liver or extrahepatic recurrence, and it turns out that when you look at liver-specific recurrence-free survival, there is a more profound difference in the recurrence-free survival. But interestingly, when you look at the rate of extrahepatic recurrence, they are identical. Then we started looking at the types of liver disease, and we found two categories that we were working with. There were patients with fatty liver disease and perfusion changes, and then there were those with cirrhosis, fibrosis, granulomatous disease, and textural changes. So what we found out was that if you look at the second group, the liver-specific recurrence-free survival in that group was amazing. It was very distinct from the other two cohorts. And then if you look at the rate of recurrence, when you divide them into liver disease versus no liver disease, there is definitely a difference, significant difference in overall recurrence as well as the hepatic recurrence. But interestingly, when you look at them classified into these three cohorts, you find out that there's no significant difference between the rate of recurrence or the rate of extrahepatic recurrence. It's the liver-specific recurrence that's different. And then most importantly, when you look at the second type of liver disease, there was very minimal rate of liver recurrence. Only 4 of those 59 patients recurred in the liver. So that's 7% as compared to around 30% in patients who did not have pre-existing liver disease or who had type 1 liver disease. This study does have several limitations. It is a retrospective study, and the micromanagement in terms of the type, duration, sequencing of systemic therapy was not studied. And then presence of liver disease and parenchymal changes were not confirmed histopathologically for a majority of these patients. So in conclusion, pre-existing liver disease and parenchymal changes are associated with patterns of liver recurrence in pancreatic cancer. Presence of liver disease through mechanisms that are currently unknown, but I believe has to do with the pre-metastatic niche formation, reduces the risk of liver metastases in these patients, and a subgroup of liver changes can identify a patient population with a very low risk of liver recurrence. Thank you, and I'd be happy to take any questions.
We'll go ahead and open the discussion.
Great talk, Kumar. When did you define liver disease? Was it just at resection, prior to neoadjuvant therapy? Looks like there is a cohort that received chemo, but that's the first question. And then, do you think the fact that you found type 1 to be significant, which is what we see with chemotherapy, and I know you did account for chemotherapy, do you think it's some sort of selection bias in the sense that those patients got more neoadjuvant therapy or a different regimen because of disease characteristics that are worse?
No, those are great questions. Thanks, Dr. Zurakat. So we looked at their first scan. So we looked at their prior medical history at the time of diagnosis, and they were screened for liver disease at the time of diagnosis. So for the neoadjuvant cohort, that was done before they got their neoadjuvant therapy. And then in the multivariate analysis, we did control for neoadjuvant therapy, and despite that, presence of liver disease was significantly associated with liver-specific recurrence.
Amber, did you look at patients who actually were heavily treated neoadjuvantly and actually went from a normal liver to, and then developed a cash liver, and whether or not that had any effect?
So that's a great question, and as I mentioned in the limitations, we did not, but I am in the process of looking at
That'd be
that.
very, I mean, we've kind of looked at least some of our data, at least in terms of perioperative outcomes and complication rates, and did not show any real difference in patients that developed um, cash liver during chemotherapy and underwent pancreatic resection.
Mhm.
But again, that was looking at short-term, outcomes, not really oncologic outcomes.
Uh-huh. Mhm.
Yeah. So it's very interesting work. It'll be interesting to
Thank
see
you.
where it goes. Thank
I
you.
appreciate it.
Okay.
That brings us to next presentation, and it's a bit provocative question actually. Is adjuvant chemotherapy needed in surgically resected pancreatic carcinoma with node-negative disease following a neoadjuvant therapy? The presenter is Dr. Abdulrahman Hamad from Pittsburgh.
Thank you. I would like to thank the organizing committee for allowing us this opportunity to present our work. Our presentation is a collaboration between us at the University of Pittsburgh Medical Center and the Medical College of Wisconsin. We have no disclosure. There is a growing emphasis on the potential benefit of neoadjuvant therapy for patients who have operable pancreatic cancer. While neoadjuvant therapy is not associated with a complete pathologic response, however, it does result in downstaging of node-positive disease to node-negative disease. And there is paucity of the literature examining the incremental benefit derived from adjuvant therapy in node-negative patients following neoadjuvant therapy. So the current study aimed to examine the prognostic implications of adjuvant therapy in node-negative patients following neoadjuvant therapy and curative intent surgical resection. And we also aim to identify high-risk features in such cohort that would be a predictor of progression-free and overall survival. And to do so, we identified patients with localized pancreatic cancer from a combined cohort between us and the Medical College of Wisconsin that underwent neoadjuvant treatment and surgical resection between 2010 and 2018. Only patients with no negative disease on file pathology were included into the analysis. Kaplan-Meier survival estimates and multivariate Cox regression analysis were used to identify both predictors of overall progression-free survival. Overall, we examined 976, of which 44% or 430 patients had node-negative disease on file histopathology. Overall, the majority of patients had a median age of 65 years, with 51% of the cohort being females. Most of the patients had either borderline resectable or a resectable tumor, and gemcitabine-based therapy was delivered in approximately 45% of the cohort, with a median number of cycles of 2.7. And finally, neoadjuvant radiation was delivered in 65% of the cohort. To continue, most patients received an open surgical approach, and pancreatoadenectomy was performed in 72% of the examined cohort, with 37% of the patients requiring a concomitant vascular resection. On histopathology, the majority of the patients had a T2 disease, a moderately differentiated tumor, with a median lymph node harvest of 26. Lymphovascular, perineural, and residual margins were seen in 22, 59, and 21% of the cohort. Adjuvant therapy was associated with improved progression-free survival for the overall cohort, as seen on the screen, 40 versus 52 months. Similarly, adjuvant therapy was associated with improved overall survival for the entire cohort, 65 versus 56 months. When we stratified by pathologic features, we found that adjuvant therapy was associated with improved progression-free survival in node-positive disease, as seen on the right side of the screen, but not in P9-negative patients, as seen on the left side of the screen. Similarly, adjuvant therapy was not associated with a survival benefit in P9 negative patients, as seen on the left side. However, was associated with improvement in overall survival in P9 positive patients, as seen on the right side. Further stratification, we found that there was a collaboration, or there was an association between survival adjuvant therapy, perineural invasion, and the receipt of neoadjuvant radiation. However, we found that in patients who had P9 positive disease, patients who were radio naive, as seen on the left side of the screen, the benefit of adjuvant therapy was much higher as compared to patients who received neoadjuvant radiation, as seen on the right side. We performed further risk adjustments since we found a lot of interactions between some of the pathologic features and the benefit seen by adjuvant therapy. And the strongest interactions that we found were between adjuvant therapy and perineural invasion, and there was a second interaction between adjuvant therapy and neoadjuvant radiation. And the relationships of these variables and their interaction with each other were examined on the multivariate analysis. So on multivariate analysis, examining factors associated with progression-free survival, poorly differentiated tumor, presence of lymphovascular invasion and perineural invasion were all associated with worse overall, with worse progression-free survival. Adjuvant therapy in patients who did not receive neoadjuvant radiation and who did not have perineural invasion was protective. And on interaction terms, we found that in patients who received neoadjuvant radiation, the benefit of adjuvant therapy was lower, which is highlighted here by the higher hazard ratio. However, in patients who had perineural invasion, the adjuvant therapy benefit was higher, as seen by the lower hazard ratio. We found also a similar story on the multivariate analysis, examining factors associated with overall survival. So patients who had an undifferentiated tumor, patients who had lymphovascular invasion, perineural invasion, or patients who needed vascular resection, these factors were associated with worse overall survival. Adjuvant therapy was also protective in patients who did not receive neoadjuvant radiation or have perineural invasion. However, when examining the interaction between adjuvant therapy and neoadjuvant radiation, the benefit of adjuvant therapy was lower, while adjuvant therapy benefit was higher in patients who had perineural invasion on final histopathology specimen. So this study is limited by its retrospective nature with the potential for selection bias. Additionally, pathologic features such as margin status, perineural and lymphovascular invasion is subject to different interpretation between different institutions. And for the purpose of this study, that was not evaluated by a second pathologist. There was variability in treatment algorithms between the collaborating institutes, meaning between the University of Pittsburgh Medical Center and the Medical College of Wisconsin when it comes to the utility of neoadjuvant radiation, the utility of minimally invasive pancreatic resection, and the indications for postoperative adjuvant therapy. And finally, this study examined an earlier cohort that received a shorter course of neoadjuvant treatment with a median number of cycles of 2.7, and the results might not be generalized to patients who receive total neoadjuvant therapy of 6 or more months. In conclusion, this study found that in patients who had received neoadjuvant therapy followed by surgical resection and had a node-negative disease on final pathology, adjuvant therapy was associated with improvement in survival, and this is particular in patients who had perineural invasion. High-risk features that we identified that were associated with progression-free and overall survival in this cohort was presence of perineural invasion, lymphovascular invasion, poor tumor differentiation, and the need for vascular resection. Finally, I would like to acknowledge our team from the University of Pittsburgh Medical Center and our collaborators from the Medical College of Wisconsin, and we're happy to take any questions.
Thank you. We have time for some few short questions, please.
Sure. Excellent presentation, a really nice study. So two questions. One maybe not so important because it's not relevant to the larger population, but within your cohort, I was trying to see in the pathology slides, how many path CRs did you get, path complete responses? And did that subset, I'm sure it's a small number and hard to make any sort of judgments on adjuvant afterwards. It's something that we struggle about a lot. But actually, what I think is maybe a more important question is that your two institutions, Medical College of Wisconsin and Pittsburgh, probably have published the best literature on CA19-9 in surgical patients and changes in CA19-9 in neoadjuvant. I was wondering if you looked at that in your multivariate analysis, and actually, one of the things that would be interesting to me is, so you have a patient, real quick, a couple of scenarios. Somebody who has a CA19-9 response, you take them to surgery. Have you looked at their post-CA19-9? Does that predict adjuvant? And how about those patients that we struggle with who have maybe a good response, but they don't normalize their CA19-9? I mean, honestly, at the end of the day, we take them to surgery. What is their post-CA19-9, and does that predict that they would need adjuvant or not? But excellent study.
Yeah, thank you for your comments. So as regarding to your questions, for the CE19-9, for the purpose of this study, we try to examine it on the univariate and multivariate analysis. However, normalization of the CE19-9, persistent elevation, or non-secretors, none of these variables were associated with any survival benefit. So we ended up excluding that from the univariate and multivariate model, and that didn't make it to the presentation. As regarding to your question about the complete path response, we saw that in maybe 5 to 7% of the examined cohort in this study. However, also that was not associated with any survival benefit. As regarding to your question about the mix, we examined that in a different study that just got accepted, looking at dynamic therapy. And this dynamic therapy concept examined patients who either had a response in their C19-9 or had a path response or a mix of these two, and how they did later on. But for the purpose of this study, we didn't look at either of these variables.
Thank you
Real
for
quick.
the talk. Just a quick question. So, can you comment a little bit about the total number of examined lymph nodes? I saw that they were significantly associated with survival. And when you look at the total number of examined lymph nodes, and you use the recommended cutoffs, how does that change the findings of your study?
Yeah, so all of our patients had a median number of lymph nodes over the recommended guidelines or over the different studies that looked at cutoffs for T1, T2, T3 patients. And it made it only into the multivariate analysis for overall survival. But we didn't look at different cutoffs and their association with anything else. Thank you.
Thank you. So our next paper, third paper, is going to be the significance of extrapancreatic extension in the 8th edition of the AJCC staging system from pancreatic ductal adenocarcinoma in the National Cancer Center database, presented by Dr. Lee from Seoul, or maybe not. Okay, we'll move on.
Thank you, Chairman. It's very honored to present here IHPBA
Oh, sorry.
2022, but I'm sorry not to attend in-person meeting due to corona pandemic. I'll talk about the significance of extrapancreatic extension in the 8th edition of the AJCC staging system for pancreatic ductal adenocarcinoma in the National Cancer Database. I have no COI. The AJCC staging system is the most commonly used staging system as an indicator for outcomes of malignancy, and it is also used the main staging system for pancreatic cancer. Since 2018, guidelines were updated to the AJCC 8th edition, and there were some changes in T and N stage of pancreatic ductal adenocarcinoma. In the previous 7th edition, whether the tumor was limited within or extended beyond the pancreas was of the main concern. In the 8th edition, however, the concept of extrapancreatic extension was removed, and T1 to 3 were divided by tumor size only. For end stage, N1 and 2 were subdivided based on the number of positive lymph nodes, where previously it was only divided depending on the mere presence of positive lymph nodes. Several reasons contributed to the elimination of the concept of extrapancreatic extension in the ACE edition. Extrapancreatic extension, EPEX, was almost observed over 90% of pancreatic cancer. So only 4% of PDAC was qualified as T1 or T2. And from the study of saccharine assay, there was no clinical significance of EPX. Moreover, tumor size rather than EPX gave a better reproducibility of T staging. However, there were limitations of those opinions. Survivor stratification of the ACE edition T staging was not correlated well even in their paper. And there were no other reports supporting that EPX has no effect on survivor. Therefore, this study aims to validate the T categorization according to the ACE edition AJCC staging system and to investigate the significance of EPX in PDAC by using qualified big data from the NCDB. For data trimming, first the code of neoplasm at pancreas was queried, and among them patients whose critical data was lacking were excluded. In the case of patients originating from the pre-malignant lesion, they were excluded in consideration of the different prognosis. Finally, about 37,000 adenocarcinoma without pre-malignant lesions were used for analysis. The demographics of all patients were as follows. T staging was done according to the ACE edition. Algebraic rate was 76.7%, 67% of patients had lymph node metastasis, and 80.9% of patients had EPX. This is graph comparing survival according to the T stage. But the number of patients was so large, there were survival differences between the T stages, but we can see that the ACE edition was less evenly distributed than the 7th edition. Even when compared to the whole stage in the ACE edition, 1B and 2A do not go down in parallel, and the ACE edition was less evenly distributed. When comparing the survival differences according to EPEX, the survival rate of EPX negative patients was significantly better than that of EPX positive patients. When comparing the ratio of EPX by T staging, EPX positive was 63.2% in T1, and the ratio increased from T1 to T3. EPX negative patients had superior survival than EPX positive patients in all T categories. When divided into 7 subgroups considering both T stage and EPX, there was almost no difference in the survival rate of the T1 EPX positive group, T2 EPX negative group, and T3 EPX negative group. If these three were combined into one group, and the T1 EPX negative group was divided into a separate group, we could make the total into 5 groups, like this, and the first T2 EPX positive group was named T3A, and the T3 EPX positive group was named T3B, because they had close survival graph. It was found that our proposal T stage performed better survival stratification than the previous classification. To check the prognostic factor, univariate and multivariate analysis was performed, and the p-value of all items was significant because the number of patients was too large, but EPX was also confirmed to be an important prognostic factor with hazard ratio 1.247. As a result, it was difficult to say that the AJCC ACE edition has better stratification than the 7th edition. And the fraction of EPX in T1 was relatively lower at 63.2%. The presence or absence of EPX made a difference in the survival rate, and it was confirmed that EPX negative patients show superior survival than EPX positive patients in all T categories. When considering both T category and EPEX, new T stage can be proposed, and the survival was distributed evenly. In conclusions, EPX is still important prognostic factor in both the overall cohort and throughout all T stages. And staging system should reinstate EPX and apply to all T stages, especially in T1, where EPX was absent in 36% of patients. Thank you for your attention.
Thank you. Thank you for joining us from Korea. Paper's open for discussion. Well, I mean, clearly, actually, I mean, the data speaks for itself, and the question is can we convince them to go back to the old system, or? And I guess that will be determined. But I think this is going to be important in helping them make the decision for the next staging system. So thank you for your work.
Thank you.
We'll move on to the next paper.
The next paper, the title is Prevalence of Diabetes and Pancreatic Insufficiency Plateau Within 6 Months After Pancreatectomy. Alexander Thomas from New York, Columbia. Welcome.
Thank you so much for the introduction. Good morning, all. My name is Alex Thomas. Again, I'm a resident at Columbia, and I'm grateful for the opportunity to present to you on the prevalence and risk factors for diabetes and exocrine insufficiency after pancreatectomy. We have no disclosures. So, we know pancreatectomy to be potentially morbid, and that when diabetes and exocrine insufficiency occur, they can impact quality of life. But when we go to counsel patients, we rely on literature that reports widely varied prevalence of postoperative disease. Potential causes include the direct removal or destruction of productive islet cells, downstream parenchymal atrophy and fibrosis related to upstream duct obstruction, and the disruption of neurohormonal feedback loops related to duodenal resection. So, recognizing that predictive factors and timing of onset are not well established, we humbly set out to look up to determine the what, when, and why of postoperative disease. To do so, we queried a database called MarketScan provided by IBM Watson Health. MarketScan covers patients with Medicare, Medicaid, and private or commercial insurance. We looked for adult patients who had a Whipple or distal pancreatectomy over an 8-year period, and the outcome of interest was filling at least one outpatient prescription for certain medications within various time periods. Given that the claims were tied to insurance, we had to limit our cohort to patients with continuous insurance for 6 months before surgery to 2 years after. So 4,700 or so patients made it into the cohort. Prevalence of preoperative diabetic medications was about 19%, and preoperative PERT medications was about 5%, PERT being pancreatic exocrine replacement therapy. Whipple was the more common operation. Most patients were aged 45 to 65. About 7% of patients were insured by Medicaid. The majority of patients either had pancreatic or periampullary malignancy, and rates of obesity and alcohol abuse were low in our sample. These figures present prevalence over time. So each time period was analyzed separately, meaning a patient could have claims across multiple time periods in these figures. We see first, as it relates to diabetic medications, that preoperative prevalence of claims was about 19%. To rise significantly to, looks like it's cut off a little bit there, but the total postoperative prevalence was almost 40% for distal pancreatectomy and nearly 30% for patients after a Whipple. When we look at PERT claims, we see that the preoperative total prevalence was lower, but interestingly, patients who went on to Whipple had higher prevalence of preoperative claims than people who went on to distal pancreatectomy. This may reflect the fact that they had some sort of an upstream obstructing lesion, perhaps in the head of the pancreas. The patterns of postoperative prevalence are consistent in that Whipple patients had significantly more postoperative claims than distal pancreatectomy patients. These dotted lines represent 6 months after surgery, so we see that the prevalence rises significantly in that period to then relatively plateau from 6 months on and onward. So that was prevalence, but we were also interested in reporting on what happens for patients who have no medication claims before surgery. So when we evaluated for incidence, we see some common patterns similar to our prevalence analysis. Operation type mattered, and then we also looked at time to the initiation of first therapy. again, we see that the median time, so at least half of patients really are having their first therapy within that 6-month period. While we're talking about incidence, I'll also mention that we did do a stratified analysis of diagnosis for incidence. We did not see a difference whether patients had cancer, pancreatitis, benign disease, or otherwise. So what other risk factors led to claims for these medication types? Well, consistently, again, operation type, distal pancreatectomy led to more diabetes and less PERT related to Whipple. Age increased the chance of having either medication. Women and patients insured by Medicaid had less diabetic medications. Comorbidities or obesity increased the chance of having diabetic medications, and then alcohol abuse increased the chance of having PERT. So here's, I think, some important information to consider as surgeons. When we look at the prevalence of diabetes claims stratified by age, we see that there's about a 5-fold increase in our young patient group compared to the national prevalence of diabetes age-adjusted. Those gaps close for older patients, and so this really suggests that for younger patients, their postoperative diabetes may be directly related to surgery, and these are patients who are going to live longer with this burden of diabetes and medications, and probably we need to focus on them when we counsel preoperatively, as well as potentially introduce any screening or intervention strategies. So patients faced with a potential pancreatectomy have a challenging decision ahead of them. They must weigh the benefit of their operation and the resection of disease against the risk of perioperative morbidity and chance of a lifelong disease like diabetes or exocrine insufficiency. When weighed against a cancer, it's a relatively obvious choice, at least to us, but as we offer patients prophylactic operations when they're otherwise in good health, we need to offer as much information as possible. So this study builds on the literature. It provides a more nuanced information based on the type of operation that we're offering, and it also suggests that claims really are most common within that first 6 months of after surgery. So it gives us a little bit of reassurance to patients who don't have claims within that time, but also maybe the people most at risk and need for interventions. I'll highlight one limitation specifically. We're basing the prevalence of disease based on treatment patterns. We did not have the ability to assess for biochemical markers to confirm. So thank you so much for your attention. I'd like to acknowledge my collaborators and my PI, Dr. Michael Kluger. For anybody who feels like helping a surgery resident out with his next research project, this QR code would direct you to an IHPBA survey that's approved and going to come out in email in the next few weeks, but we figured we'd get a jump on it here. Thank you so much. I'd be happy to take any questions.
Thank you. So the presentation is now open for our discussion. Please. In that case, Yeah, we were able to. We didn't see any difference in terms of the incidence rate coming out of it. Well, about 60% of patients had malignancy, either pancreatic or periampullary. Unfortunately, and it was less than 10% of pancreatitis and benign. There was about 20% that was not otherwise specified that we were based on ICD codes, and we just couldn't tell about 1 in 5 patients what their underlying etiology was.
How about with adjuvant therapy, patients that received radiation for their malignancies, or was there any difference in those patients?
Yeah, that's a great question. We didn't assess for radiation therapy.
And again, a lot of times those patients, you'll see them, they come back and they're very atrophic remnant pancreas, and over the year or so after surgery, they really kind of atrophy away. So I think it's important to still follow these people kind of long term for that.
Nice presentation. I'm a Daan Kmes, PhD student in the Netherlands. Did you take medical history into account, for the prevalence of diabetes with pancreatectomy? Did you stratify?
Sorry, the prevalence of diabetes for what?
Medical history.
Yeah, thank you for that question. So I didn't include it here, but we did include in the multivariable analysis the preoperative use of diabetic medications or exocrine replacement therapy was included. So it was factored into the risk factors that I presented. One thing I didn't mention in terms of the methodology, given that sometimes diabetes specifically can kind of present as a neoplastic process for patients with pancreatic tumors, we actually, there's no guides in the literature about when to cut things off, but we decided to exclude the 30 days prior to surgery to try to exclude at least some patients who are presenting with diabetes as their presentation with their tumor. And so that may offer some benefit to the methodology. But.
Some might argue that you have quite low figures on PERT. We don't have Keith Roberts in the audience in Birmingham, but he would say all would have it, and we would even increase survival. What's your opinion on that?
Yeah, I believe I completely agree with that. The literature on PERT suggests that we probably under-recognize it, and then even when we recognize it, we under-treat it. Patients are inconsistent with taking the medications. We fail them to educate them on how to take it. So I believe that we probably, based on the fact that we're only looking at medications that patients filled at the pharmacy, we probably are underestimating the rate of PERT. This actually does suggest that the amount of postoperative PERT is higher than prior studies, but I have a feeling we're still underestimating it.
Maybe. I mean, it's in the guidelines, but the underlying evidence is quite weak, to be honest.
Yeah, we actually did, and thank you, that's a great point. In terms of, for anybody who couldn't hear the stratification by insurance, it did not affect the receipt of PERT. It did affect the receipt of diabetic medications. So patients treated by Medicaid were treated less with diabetic medications than patients with private insurance, which is the referent group. And because this is an insurance claims database, we did not include patients who were uninsured, who may be the most vulnerable and the least likely to get any therapy.
Thank you.
Thank you all. Thank you very much.
So our next paper will be defining operative thresholds for high-volume pancreatic duodenectomy centers to improve surgical outcomes. Presented by Dr. Ju from the University of Texas Southwestern in Dallas.
Hi everybody, good morning. My name is Michelle Ju and I'm a resident at the University of Texas Southwestern Medical Center in Dallas. Today I'll be presenting our research, which is entitled Defining Operative Thresholds for High-Volume Pancreaticoduodenectomy Centers to Improve Surgical Outcomes, and I have no disclosures. So we know that the performance of pancreaticoduodenectomy and other complex cancer operations at high-volume centers is associated with improved outcomes, but the actual threshold of case volume that meaningfully impacts surgical outcomes is fairly unknown. And so in this study, what we aimed to do was to determine a clinically meaningful cut point for defining what a high-volume pancreaticoduodenectomy center is, and to also assess the impact of hospital volume on both oncologic and surgical outcomes. We identified adult patients in the National Cancer Database who were undergoing pancreaticoduodenectomy between 2004 through 2015. The National Cancer Database is maintained by the American College of Surgeons and receives hospital registry data from over 1,500 Commission on Cancer sites. This captures about 70% of incident cancer cases in the United States. We identified a total of 32,333 patients who met this criteria. We then excluded patients who had unknown surgical margins, unknown lymph node exam status, or missing date of last contact or death. And this left us with a final analytic cohort of 30,873 patients who then we performed cut point mapping on. We built an adjusted multivariable model with restricted cubic splines to predict 5-year overall survival according to average yearly case volume, which was adjusted for demographic and clinical pathologic factors that were chosen a priori. We estimated the average yearly case volume as the total number of pancreaticoduodenectomies performed at a given facility over the number of years that that facility had reported to the National Cancer Database. So for example, if a unique facility ID contributed 30 patients to our study cohort and we had 5 years of reporting data for them, we averaged their yearly volume as being 6 Whipples per year for the purposes of our calculations. This data was then further analyzed using a change point procedure to identify the threshold of average yearly case volume, after which improvements in overall survival had either greatly decreased or had plateaued altogether, and the number of change points was set to 1 a priori to reflect a single transition between 2 linear models. We identified a cut point of 24.6 cases per year with a 95% credible interval of 21.8 through 21.0. And so on the basis of this cut point we identified, we defined in our study a high volume center to be those performing 25 or more PDs per year, and low volume centers as those performing less than 25 PDs per year. We utilized chi-square tests to analyze categorical group differences, and then we built a logistic regression model to assess the impact of hospital volume on the following outcomes, which were the achievement of an R0 resection, the adequate lymph node examination of 15 or more nodes, unplanned readmission, and 30-day and 90-day postoperative mortality. Our high volume group ended up consisting of 4,073 patients, which is about 13% of our study cohort. In looking at facility characteristics, we found that 100% of high volume centers in our study were academic centers. However, among the low volume centers, there was a mix of community, academic, and integrated network cancer programs. The mean yearly volume among our high volume centers was approximately 48 cases a year, whereas the mean yearly volume varied significantly among our low volume centers, from an average of 1.2 Whipples a year at the community programs that were low volume to 10.9 at our academic centers. In looking at patient characteristics, we found that a higher proportion of patients in the low volume group were racial and ethnic minorities, so a higher percentage of non-Hispanic whites, 85% at high volume centers compared to 77.3% at low volume. While the overall uninsured rate in our study was fairly low, it was still higher in the low volume group at around 3% compared to 1%. We also found that patients in low volume centers tended to be less well educated and to be poorer on average. So the percent no high school degree quartile is based off of US Census data. It stratifies the percent of adults living in a census tract that never graduated high school. And you can see here that while only 8.7% of those in the high volume group were in quartile 1 for percent no high school degree, meaning 21% or more of adults living in that census area did not finish high school. This was 16%, so twice as much in the low volume group. And similarly, we see a higher percentage of patients living in the lowest quartile for median income, which is an average of less than $38,000 a year, 16% in the low volume group compared to 12% in the high volume group. In terms of oncologic and surgical outcomes, we found that high volume centers were associated with a significant improvement in surgical outcomes. So patients who underwent their operation at a high volume center were over 30% more likely to have an R0 resection. They were also significantly more likely to undergo an adequate lymph node evaluation with an odds ratio of 2.63. There were no statistically significant differences in unplanned readmission. 90-day and 30-day postoperative mortality were significantly lower in the high volume group, with odds ratios of 0.34 for 30-day mortality and 0.48 for 90-day mortality, and this was adjusted for demographic and clinical pathologic factors as shown below. Finally, overall survival was also improved at high volume centers. Shown here is all stages combined, and you can see that the high volume curve, which is that blue curve, had a median overall survival of 27 months compared to 21 months in the low volume group, and this was also true for stage-specific survival. So in conclusion, treatment at a high volume center is associated with significantly improved oncologic and surgical outcomes, and the performance of 25 pancreaticoduodenectomies per year is a clinically meaningful cut point to differentiate between high volume and low volume centers, and this threshold can be considered when evaluating regionalization of pancreatic cancer care to improve patient outcomes. Thank you all very much. I'm happy to answer any questions.
Thank you. We'll go ahead and open the discussion.
Thank you for that presentation. Great job. Mary Delhoff from Iowa State. I would imagine that within each institution, if you have one surgeon doing those 25 operations or 7 surgeons doing those 25 operations, that might matter because you might have low volume surgeons. Were you able to look at that in your database and any way to address that?
Sure. So in the National Cancer Database, it does not actually capture individual surgeons. It only gives us de-identified facilities, so we have an ID. We can tell the general region in the United States that comes from, but we are not able to look specifically at surgeons. I know that there are some other studies that have looked at variability in surgeon volume, but they tend to use other types of data sets that are not NCDB to do that, or state-specific, institution-specific. So unfortunately, we were not able to look at that.
And again, this just goes to the difference between Europe and America. Again, you see the vast majority of cases are still being done in low-volume centers in the United States, whereas in Europe, they've been able to regionalize, these complex diseases. And again, I mean, this is just basically you guys have shifted Brookmeyer's number from 4 to 25, which, again, goes towards, do we need to work harder towards, regionalization and at least, centers of excellence, kind of, lines like they do in bariatric surgery and that. So it's, again, very provocative.
Absolutely. I think that study, that you've referenced, the 2002 paper, was certainly one of the first papers, I think, to show very strong evidence for this. But like a lot of other studies, they used just sort of quartiles or tertiles to define. And so that's part of the impetus that we wanted to do this study, was to try to come up with a number that had some potential clinical meaning that could then be used to look at policy and things as you discussed. But
And I think the other game, in terms of your economic and insurance kind of data, though, again, with the high proportion of academic centers and the high volume things, but people travel to those centers. Those are the patients with means will travel, whereas if you don't have means, you stay local.
thank you very much.
So, next presentation, preoperative kidney function, acute kidney injury and risk for adverse postoperative outcomes after pancreatectomy. It's a new twist. Oskar Swartling, Karolinska, Sweden.
Thank you. Good morning, and thank you for the opportunity to be here today. My name is Oskar Swartling. I'm a physician and PhD student from Karolinska Institutet and Karolinska University Hospital. And this presentation will be about our work on acute kidney injury after pancreatourinectomy. And I have nothing to disclose. Acute kidney injury, or AKI, is defined as a sudden loss of glomerular filtration rate. The etiology is multifactorial. It is often found in patients with critical illness or patients using nephrotoxic drugs. It has been estimated that about 10 to 20% of all hospitalized patients develop some degree of acute kidney injury. But this is important because also small losses of glomerular filtration rate is associated to long-term morbidity. It is known that acute kidney injury is particularly common in the surgical setting, although there is limited knowledge of acute kidney injury after pancreatourinectomy, or PD. For this study, we included all adult patients undergoing PD at Karolinska University Hospital between 2008 and 2019. This is based on a prospective cohort where we then added data from the electronic health records in order to define acute kidney injury, and I will come back to this later. The outcomes of interest were other postoperative complications, here analyzed with differences in odds, short-term mortality, which we defined as 30 and 90-day mortality, analyzed with Cox regression, and then we also investigated other preoperative risk factors for developing acute kidney injury after surgery. The most common classification of acute kidney injury today is based on kidney disease improving global outcomes definition. And this is based on either changes in serum creatinine or urine output. The reason for this is that recent studies suggest that acute kidney injury can go with only changes in urine output and with relatively stable creatinine levels. Since our electronic health records only includes urine output for 24 hours, we modified this slightly, and for urine output used under 0.5 for 24 hours instead. So in order to define acute kidney injury, we then collected data on serum creatinine variables measurements 7 days after surgery and urine output 2 days after surgery. It's then recommended that acute kidney injury is staged, and this is again based on changes in serum creatinine and urine output. And here one can also note that for stage 3 acute kidney injury, there's also a criteria for the initiation of dialysis or kidney transplant. So in total, we included 970 patients, of which 20 died and 11 had started dialysis in the direct post-operative period. When we used this criteria based on creatinine and urine output, we identified 137 patients, which is 14% of all patients that had any stage of acute kidney injury. And here we found that stage 1 or mild AKI was most common, followed by stage 2 and then stage 3. When looking at changes in creatinine, we saw that it was most common that these changes occurred day 1 or 2 after surgery. We then investigated preoperative risk factors for developing acute kidney injury after surgery. And here we found that male sex, a lower preoperative EGFR, hypertension, congestive heart failure, and the preoperative use of RASI or diuretics were associated to developing acute kidney injury. This is a busy slide. I will not go through this in detail. It presents the unadjusted and then stepwise adjusted odds ratio for other post-operative complications by the presence of acute kidney injury. And here, some of the outcomes included were clavien grade above or equal to 3A, ICU admission or hospital stay above or equal to 14 days. And in general, we saw that patients that did develop acute kidney injury had a higher odds of all the other post-operative complications that we assessed. And the results were similar when we adjusted for comorbidities at baseline, preoperative EGFR, and the use of potential toxic drugs. And this is just the overall survival the first 90 days after surgery by the presence of post-operative acute kidney injury. And here, I think it's the yellow line that's acute kidney injury. And in another analysis, we used Cox regression and stratified by acute kidney injury stage. And there we found that there was a trend towards higher hazard for each AKA stage for short-term mortality. And the results were similar for 30 and 90 days. So in conclusion, using these standardized criteria based on creatinine changes and urine output, we found that 14% of all operated patients developed some degree of acute kidney injury. This can be compared to earlier studies showing an incidence between 10 and 20%, although the first study there mentioned includes other types of pancreatic resections, and the second study only uses the KDIGO creatinine definitions. The preoperative risk factors that we identified are all known risk factors for acute kidney injury in the general population, so also outside the surgical setting. And we also found that acute kidney injury was associated to other post-operative complications. Of course, here's very difficult to say anything about causality. It's quite possible that another post-operative complication preceded acute kidney injury. However, we did find that the creatinine changes occurred early, day 1 and 2, and in critically ill patients at least, there are evidence suggesting that acute kidney injury is an early sign of deterioration. And then finally found that acute kidney injury was associated to increased short-term mortality as well. Thank you.
Thank you. So, questions, please.
I have one, or a couple actually. So in a couple of factors again, so in patients with, chronic kidney disease, do you guys routinely use goal-directed therapy or change your intraoperative fluid management in those patients in this cohort?
So you mean that the fluid administration would
In terms of
change?
using, as opposed to just to let the anesthetists do whatever they want versus using, a data-driven, non-invasive cardiac output monitoring or...
I don't think I can answer what they do during the surgery from the anesthesiologist, but
But you don't have any protocols in that, in terms of how you...
not that I'm
do your-
aware of, but we were unable to include information on fluid administration here. And of course, both fluid restriction and overload is associated to acute kidney injury. So,
And then the other question, again, we know, I mean, at Karolinska, do they use routine preoperative biliary drainage? Because clearly, patients who are deeply jaundiced have a higher incidence of, postoperative renal failure and lots of other kidney issues.
Yeah.
So, I mean, was there any correlation between preoperative bilirubin or usage of stents that you're aware of?
we didn't have that information in this data set.
Yes, please.
Good morning. Thank you for your presentation. Mohammed Kris from the University of Arizona. We know that EGFR is a better surrogate for renal function. Why did you not use EGFR in your analysis to define acute kidney injury? And do you think if you had used your data or results would have changed? Thank you for your...
Thank you, that's a good question. So the KDIGO criteria is based on creatinine changes. It doesn't include changes in EGFR, but you're right that EGFR is a better measurement. So I didn't present this here today, but we also looked at preoperative EGFR and complications after surgery. And when one of the adjustments here included EGFR, so not creatinine, but the definition of acute kidney injury today is based on creatinine changes and urine output. So that's why we used it.
May I ask, early recognition of complications following pancreatic resection is probably one of the keys to increase these, well, not survival only, but morbidity in general. Do you think this could be a tool in the toolbox that you can implement or use to identify those potential, an extra eye on that particular patient?
Yeah, I think so. I think monitoring of urine output and creatinine measurements early could be important. And this is just my gut feeling when going through all these health records. But I think awareness is quite low. It's just mentioned when there's obviously acute injury, they're waiting for dialysis or something. So, yeah.
So there might be more to come. Thank you.
Thank you.
Okay.
Next paper will be National Trends and Factors Affecting the Utilization of Neoadjuvant Chemotherapy, presented by Dr. Vega, who's from Chile, but is representing Tufts University in Boston.
Yeah, excellent. So good morning, everyone. I'm Eduardo Vega, and I'd like you to present trend of neoadjuvant chemotherapy utilization in proximal cancer. So this is going to be divided in background, objective, patient, method, result, and summary. So today we have multiple possible permutation of chemotherapy and surgery. We have the total neoadjuvant treatment, as you know, preoperative treatment, that means pre- and post-operative chemotherapy, and adjuvant chemotherapy. We have seen in the session in the morning, and we have seen also in multiple publications, the clear benefit of preoperative chemotherapy. However, there is not current analysis of trend in the utilization of preoperative chemotherapy from our national reality. Identification, and also I wanted to mention that we wanted to proceed any barrier that we can identify to receive preoperative chemotherapy. So those are going to be our two objectives of the study. One, analyze the trend of preoperative chemotherapy in national data, and which are the barriers to get preoperative chemotherapy in our population. So this is a concept diagram. I think that you have to look it up. This is an NCDB data, again, 2004 to 2017. We choose only proximal cancer. That was a cohort of 128,000 about. We exclude many people, and the analyzed patient cohort is only 23,206. I think the most important part of this is how we study the trend. We finally study the trend with a man candle with the ascent slope to see whether the trend is actually significant. So let's talk about result. This is the graphic, bar graphic. You see how the trend from 2006 to 2017 has been increasing, up to from 7.3 up to 36.8%. But this is the most, probably the most fascinating graphic of the studies, where we can divide it in the different permutation we have. The most important color you want to see is the black, that it means that no chemotherapy has been received. And you can see in the red, the neoadjuvant total chemotherapy, that in the NCDB means that we only have register of receiving only preoperative chemotherapy, and the perioperative chemotherapy, that both are trending up. However, I haven't shown you where significant or not. But you can see the adjuvant chemotherapy is stable, that's the blue color you see in the graphic. So in conclusion, and there is a significant trend down of people who don't get any chemotherapy. And there is an significant increase of people who receive either total neoadjuvant chemotherapy or perioperative chemotherapy. And I have to remind you, this is a cohort of patients that all of those patients got surgery. Then we went to see what are the barriers so we can identify the problem and probably target that population. Obviously, older age, longer distance to the hospital, advanced age, and poorly differentiated tumor. While people who are more likely to receive preoperative chemotherapy are the ones that we know, academic facility, high institutional volume, as we already talked about it, and private insurance. So in summary, 1 out of 5 patients receive no chemotherapy still. And I have to remind you, these are patients who actually get the surgery. 3 out of 4 of patients receive no preoperative chemotherapy. And preoperative chemotherapy is increasing. An omission of preoperative chemotherapy is associated with non-modifiable and modifiable factors that we can target. That's it. Thanks so much.
Paper's open for discussion.
I have one. In the US, in upfront resectable pancreatic cancer, do you give neoadjuvant chemotherapy outside clinical trials?
You mean in our practice?
Yeah.
Yes, we do.
You do? I don't think that will happen in Europe yet. We are awaiting a few studies on upfront resectable cases. Borderline is another thing.
Yes. I think you make the argument here that we don't do it here either. I mean, it's done in most of the academic centers. Now it's kind of transitioned, but I think in the community, where most of the cases are done, it's still not. And that's, you can see that by the numbers of still only 20% of the patients. But it's been a slow fight, but hopefully it's going to continue.
Yes. Thanks much.
Any other questions? Great, thank you.
Thank you. So, yeah, second last. Identifying drug candidates for pancreatic neuroendocrine tumors based on differently expressed genes. And we have changed the presenter. It's Mary Dilhoff. Please.
Good morning, Mary Dilhoff from Ohio State. Thank you for allowing me to present the work of my colleagues. As you can see, I am not Dr. Pollack, and I will do my best to present their work, their hard work. So pancreatic neuroendocrine tumors are a heterogeneous group of neoplasms. The pancreas is one of the most common primary sites. 12% of gastroenteropancreatic neuroendocrine tumors are pancreas primary. While resection remains the cornerstone of curative intent treatment, for localized PNETs and even patients with limited metastatic disease, systemic therapies are generally indicated for patients with more advanced disease. In recent years, the combination chemotherapy of capecitabine and temozolomide, CAPTEM, was reported to be efficacious for metastatic well-differentiated pancreatic neuroendocrine tumor, which has drawn attention to novel attempts at combinations of systemic therapies. Unfortunately, most systemic therapies for PNETs have demonstrated only disease stability or low response rates, and improvement in progression-free survival, but not overall survival. As such, there's ongoing need to identify non-surgical treatments and novel systemic therapeutic options. Cancer genomics, especially transcriptome analysis, has been increasingly used for cancer screening, tumor genetic profiling, molecular subclassification, and clinical outcome prediction. Genomic analysis also presented opportunities to identify potential novel therapeutic targets. The Connectivity Map, or CMAP, is an online tool that integrates a database of over 1,300 FDA-approved small molecules with data for more than 7,000 gene profiles. The objectives of this study were to identify potential novel therapeutic targets and drugs related to the treatment of pancreatic neuroendocrine tumors using publicly available databases, to generate a list of promising drug candidates based on CMAP and based on hub genes, and to define underlying anti-tumor mechanisms of these compounds and provide theoretical support for their application in treating pancreatic neuroendocrine tumors. The methods, the oligomicroarray data were downloaded from these publicly available databases. The data was processed by log transformation and normalized. Functional and pathway enrichment information of the differentially expressed genes was obtained using both Gene Oncology, or GO, and Kyoto Encyclopedia of Genes and Genomes, K. Potential therapeutic drug targets were identified using Connectivity Map, or CMAP. As you can see here in the results, on the left-hand side, you can see there's differentially expressed genes. So in the databases, there were 63 pancreatic neuroendocrine tumors and 9 normal pancreas that were profiled. You can see both on the left-hand side that both of those, the tumor versus normal pancreas, had different genetic profiles. And on the heat map on the right, you can see the clustering details for the differentially expressed genes. The functional analysis, so using the KEGG and the GEO databases of the differentially expressed genes, found 23 genes that were downregulated, as you can see, and 6 that were upregulated. The pathways associated with these genes have multiple mechanisms, from nitrogen metabolism, GABAergic response, C-leptin type receptor signaling, amongst many others. Here were those hub genes that were identified, and so these are related genes. You can see both the upregulated genes and the downregulated genes. These were the 10 most upregulated and the 10 most downregulated. And then when you look at these genes and their interaction, when you group them together on their protein-protein interaction, you can see all these are very related. And so those are the upregulated on the left and the downregulated genes. The 20 hub genes were then input as an index gene profile in the CMAP database. So here's where we're looking to try to find the drug targets. That CMAP database uses a small molecule library and an algorithm called the Weighted Connectivity Map score to calculate the potential gene expression profile of each drug when they are used on certain cell types. This identified 124 drugs that had a high score and 90 drugs that had a low score, and these were all screened then. Here you can see several of these drugs. Actually, they used 2 databases, and of these 2 databases, only 1 drug came out on both databases, and that was canertinib, which is an EGFR inhibitor. You can see the top drugs here. Several EGFR inhibitors, as you can see, tyrosine kinase, so many of our common mechanisms. In conclusion, differentially expressed genes were identified in pancreatic neuroendocrine tumors using publicly available databases. 20 gene hubs were identified using protein-protein interaction analysis and verified with the GEO datasets. There were 12 drug candidates that were identified in the 2 databases, and one of them, canertinib, was identified in both of those databases. The top drug candidates were mostly EGFR inhibitors, erlotinib, canertinib, and WZ4145.
Others include a glucosidase inhibitor, acarbose, and a glucokinase inhibitor, as well as a glucose-dependent insulinotropic receptor agonist. Obviously, these drugs need to be have both in vivo and ex vivo studies done, but this is a hypothesis-generating study and helping to identify some of these targets. Thank you. Have any questions?
Thank you. Questions from the floor? Use the mic, please.
No, it's far from your armor, so it's hard.
Was the sample size just 69 patients?
60, yes, so 63 of peanuts and 9 of normal. And a downside to this is that there's no clinical annotation to this, right? So we don't know grade, we don't know anything else about those tumors, really, in this database.
That was my question.
I know, Mary, it's not your work, but I mean, is there any, did Tim tell you anything about any kind of in vitro or in vivo kind of data on some of the EGFR inhibitors in these? Or?
So this, this is really hypothesis generating, and so they don't,
I assume the next step is to go to the lab and figure it out.
Right, like, so this helps people know, like, like a drug company to see, where do we go and what drugs really should we screen next.
Thank you.
Thank you.
Good work for filling in. But with Tim's not really big shoes, so it's not a problem. So our final paper of the session is going to be early recognition and management of complications after pancreatic surgery, presented by Dr. Jasmine Smits from Regional Academic Cancer Center in Utrecht, Netherlands, as well as on behalf of the Dutch Pancreatic Cancer Group.
Thank you for the introduction. As you all know, pancreatic surgery is complex and associated with a high risk of complications. One of the most feared complications is the occurrence of postoperative pancreatic fistula, mostly due to the association of other complications like organ failure through systemic inflammatory response and also major bleeding through vessel erosion. Due to the association of these complications, fistula-related mortality as high as 18% has been reported. So in this study, we tried to find an explanation for differences in mortality within the Dutch centers. So what we did is we divided all Dutch centers performing pancreatic surgery into 4 groups based on postoperative mortality. And what we saw is that the incidence of major complications was not really that different between the centers, but we did see a major difference in failure to rescue rates, being mortality within patients with major complications. So we concluded that not only the prevention of complications, but maybe even more importantly, the adequate management of complications is important in improving outcomes after pancreatoduodenectomy. So that brings us to the aim of the FORCE trial, which was to evaluate if the implementation of an algorithm for early detection and minimally invasive management of postoperative pancreatic fistula results in a lower rate of major complications and death after pancreatic resection as compared to current practice. The FORCE trial is a nationwide stepped wedge cluster randomized controlled trial, which means that over a time period of 22 months, we implemented an algorithm in all centers in the Netherlands performing pancreatic surgery. So after 5 weeks, the algorithm was implemented in the first center, and then in stepwise manner, we continued until it was implemented in all Dutch centers. So the primary endpoint of the study was a composite endpoint of the 3 most severe complications associated to pancreatic fistula, bleeding requiring intervention, new onset organ failure, and 19-day mortality. And all outcomes were assessed by a blinded adjudication committee. For statistical analysis, we used a mixed effect regression analysis, adjusting for both study design using center and time, but also for baseline variables associated with a high risk of pancreatic fistula or the primary endpoint. And for continuous outcomes, we use proportional hazard regression and zero inflated binominal regression. So the algorithm itself, it's too complex to discuss here in detail, but I will try to give you insight into the algorithm in this slide. So what we did is all patients had to be standardly evaluated on a daily basis from day 3 to day 14. And you have to use these variables, so you have to use vital signs, C-reactive protein levels, white blood cell count, the drain amylase levels, and then daily consult of a pancreatic surgeon. You have to enter all these variables into the algorithm, and you get 3 advices: whether or not you should start antibiotic treatment, if you should make a CT scan, or if, and also if drains should be removed. After a CT scan was performed, there was a second part of the algorithm, meaning a standardized evaluation of the CT scan, resulting in one of 2 advices: whether or not you should perform minimally invasive drainage, and in difficult cases there was an expert panel that could be consulted during the trial. So the algorithm was incorporated into a smartphone application, and from the data from the smartphone application told us that the application was completed over 9,000 times in 22 months of the study, and was completed in 94% of patients on a daily basis. Adherence to the advice to perform a CT scan was followed in 75% of advices. To start antibiotics was followed in 70% of cases, and adherence to the advice to remove drains was followed in 83%. So overall, very high adherence rates. So a total of 1,805 patients were included, and patients were equally distributed between the groups, so the control group and the intervention group. There also was a wash-in period, which was like a testing practice phase after we implemented the algorithm, and these patients were excluded from the final analysis. So this slide shows the baseline characteristics, and it's what you would expect from this cohort. So about 50% of patients was male, mean age was 65 years. The majority of patients had an ASA classification of 1 or 2. 75% of performed resections were pancreatoduodenectomies, and the underlying disease was pancreatic ductal adenocarcinoma in 37% of patients. So this slide shows the outcomes, and as you can see, the primary endpoint occurred in 14% of patients in the control group versus 8.5% of patients in the intervention group, which is clinically relevant but also statistically significant decrease in the primary endpoint. And when we look at the individual components of the primary endpoint, you see that this accounts for all individual components. So bleeding requiring intervention occurred less frequently after implementation of the algorithm. Organ failure occurred in 10% of patients in the control group versus 4% of patients in the intervention group. And most importantly, 19-day mortality was decreased from 5% in the control group to 2.7% in the intervention group. So an almost 50% decrease in 19-day mortality on a nationwide scale. This slide shows the first part of the healthcare utilization. Patients were less frequently admitted to the ICU. The length of ICU stay was 4 days in both groups. Length of hospital stay was comparable in both groups, and readmission rate was 20% in both groups. So when we look at the direct effect of the algorithm in terms of CT scans, antibiotics, and minimally invasive drainage, you see that there were more CT scans performed, more often antibiotics were administered, and there were more percutaneous drainages performed. But more importantly, all these interventions were done earlier. So the CT scan was performed 2 days earlier in the intervention group. Antibiotics was given 1 day earlier, and minimally invasive drainage was also performed 1 day earlier. So conclude, the nationwide implementation of an algorithm for early detection and minimally invasive management of postoperative pancreatic fistula leads to a decrease in major complications and death after pancreatic resection as compared to current practice. I would like to thank you for your attention, and we made a smartphone application incorporating the study algorithm, and you can download it using this QR code. Thank you.
Paper's open to discussion. Look, quick question. So do you think this needs to be applied to all patients, or should it be stratified to patients who are at high risk for pancreatic fistula? I mean, clearly the complications are related to pancreatic fistula. And should it be applied to patients who either have a high pancreatic fistula risk score or elevated drain amylase on day 1, as opposed to generalizing it to all pancreatic duodenectomies?
So that's something that we thought about when designing this trial, and it's also something that we will further evaluate in the Porsche 2 trial. But at this stage, we chose to include all patients because also patients with a low risk of pancreatic fistula are at risk of developing complications, and because the algorithm itself is not causing any additional risk for the patients, we chose to do it for all patients in this stage. Yes.
The other thing I was interested in is in the difference in your failure to rescue rate between the different centers. Again, all high volume centers. And is there anything that, as you've looked at those, what's happening in a high rescue rate center versus a low rescue rate center? What's different? ICU, critical care, resources, interventional radiology.
Yeah, I think it's it's the entire package. It's all everything is necessary, and we did an additional subgroup analysis of the comparing high and low volume centers within this study. I think that's the next slide. Yeah. So what we did is we divided patients into two groups based on hospital volume, and we used a cutoff of 45 pancreatic resections per year. And we saw that in the medium volume centers, you see a major decrease in mortality from 7% in the control group to 2.7% in the intervention group. And you see the same, you see also the decrease in high volume centers, but this decrease is a little bit less obvious. But you see that mortality rates after implementation of the algorithm are comparable between the medium volume and the high volume centers.
I mean, isn't the key thing awareness?
Yeah.
To recognize these potential complications early on and deal with them, as you nicely show here. And that goes back to what we discussed about centralization. We have not got rid of fistulas. POP, B, and C, they're still there. Every honest institution have them, and they're reporting 8 to 12%. But you also get an increased knowledge about how to handle it. And I don't think that can be replaced by an app. You also need a clinical input.
Yes, you do. That's very important, and that's also we urge that also throughout the trial, but also in the smartphone application. So you have to look at your patients. You have to.
Yeah, and I know there is a wish also in Holland, the Netherlands, to decrease the number of units that actually do PDs, and they are now down to 17.
Yeah.
Which may be 5 too many.
Back microphone.
Yes, Patricio Polanco from UT's of Western Dallas. Great work as we're now used to from your group. It's still interesting though that it's 5% mortality in the control group, which for our own overall standards I think is still on the higher side. And I echo the comments. Is your study impacting more the low performers? I'm just trying to wonder, in the United States nationwide mortality is 3% or less, and the high performers is less than 2%. Do you think this algorithm will be equally beneficial, lowering the mortality rate by half? Meaning, can we get from 2% to 1% with this? Is your study truly applying a combination of Hawthorne effect plus uplifting the performance of the low performers rather than impacting equally all the centers across your study? Thank you.
Thank you. So I think that the effect is most clearly seen in the low volume centers. But 5%, yeah, we looked at the mortality rates reported in literature because we also thought that 5% is quite high. But this is 90-day mortality, so mostly in literature the 30-day mortality is reported. So 5% from 90-day mortality, that is comparable to what is reported in the literature. And also this is nationwide mortality, so it's not only the high volume centers. We included all centers performing pancreatic surgery in the Netherlands. And if you decrease the mortality rate to 2% on a nationwide scale, that is as low as it has been reported in literature if you look at the nationwide cohorts. Thank you.
What happened to the patients that actually didn't follow the advice of the app? That 25%, when they, I mean, do you have data on their outcomes different, or?
Yeah, it's difficult because
I know it's sensitive.
Yeah, no, it's not. Yeah, no, it's not really sensitive, but it's difficult because the algorithm was a multi-level algorithm, and it's also the main part of the algorithm was to increase awareness. So it's difficult to distinguish what the direct effect is, and if you do not make a CT scan today, but you do it tomorrow,
Last question.
Thank you for your talk, Mohammed Kreis, University of Arizona. Do you think the level of training of the surgeon makes a difference? Example, in low volume centers, for example, for fellowship trained dedicated surgeons versus not? Do you think your algorithm would help those fellowship trained surgeons in low volume centers? Thank you.
Thank you. So I think, of course, training is important, and the algorithm can help, especially those who are not performing pancreatic surgery on daily basis. So the relatively low volume centers, the algorithm can help them to standardize their post-operative care, especially. Yeah, but I think training is, of course, very important.
Thank you. With that, we'll go ahead and close the session right on time. Thank you.
Well done. Thank you. Yeah. In 2011, Dutch published a paper in Good General Surgery on their urge to centralize, and very little happened. So there are a lot of strong wills, and they still, I had to say, because there's still a number of small. Yeah, yeah. It's 60 billion. There should be a catch up of 2 to 3 million per unit.
It's 2.5 hour drive, and across the whole country.
Yeah, you're outside.
We have people that drive, 10 hours.
It's different.
Ladies, did you all stay out too late last night? 3. Good. I'm glad to see you become much more mature over the week.
Okay. So, nice meeting you.
It was nice to meet you. Yeah. What time are you leaving? 6:30. All right, well. Yeah. When are you leaving? Tomorrow. Think it'll be, yeah. And how was the Music Man yesterday?